Your patient has failed Lexapro Zoloft Defexor and they're still suicidal. Now what? In this video, we are going to address what to actually do next, and at the end, we'll discuss the biggest mistake residents make when treating depression. Let's start with discussing treatment of postpartum depression. Historically, postpartum depression was treated similarly to other depressive disorders, usually SSRIs plus therapy, and we still do use that as treatment. But now we have actual medications specifically approved for postpartum depression. One of these is Brexanolone. Brexanolone is an IV neurosteroid derived from allopregnanolone, which is a metabolite of progesterone. It is given as a continuous 60-hour IV infusion in a monitored setting because it can cause profound sedation and even loss of consciousness. The major advantage is the rapid symptom improvement, which is important because severe postpartum depression can impair bonding, functioning, and infant care. But realistically, because of the cost, monitoring requirements, and logistics, is not commonly used outside of specialized centers. More recently, we have Zuranolone. This is an oral neurosteroid approved for postpartum depression, and it is taken for 14 days. One of the major points that people remember is the rapid onset. Some patients improve within days instead of waiting weeks like traditional antidepressants. But remember, it can cause sedation, dizziness, impaired driving, and it is a controlled substance. So let's move on to treatment-resistant depression treatments. One of the biggest frustrations in psychiatry is waiting 4 to 6 weeks for antidepressants to work while patients continue suffering. This is one reason why NMDA modulating treatments have become so important. One of these is Auvelity. So Auvelity combines dextromethorphan with bupropion. The dextromethorphan acts partially through the NMDA antagonism and sigma-1 receptor activity, while the bupropion increases the dextromethorphan levels through the CYP2D6 inhibition. Clinically, patients often report improvement faster than traditional SSRIs, which is great. But remember that bupropion still has those contraindications. Don't give this to someone with epilepsy or a history of eating disorders. Then there is Esketamine, or Spravato. Esketamine is a nasal spray, NMDA antagonist used for treatment-resistant depression and depressive symptoms with acute suicidal ideation or behavior. IV ketamine can be used as well, but it is not FDA approved yet, so it is less likely to be covered by insurance. One major advantage is the rapid symptom improvement, which is amazing. But this is not a casual medication. Patients taking Spravato require REMS monitoring, blood pressure monitoring, observation after administration, and transportation planning because of the dissociation and sedation it can cause. I've seen it work miracles with patients. Now let's talk about one of the most important medications in psychiatry, lithium. Lithium has the strongest evidence in psychiatry for reducing suicidal behavior and suicide deaths. And this matters because many antidepressants improve mood, but lithium appears to have specific anti-suicidal effects beyond just the antidepressant effect. And this is why lithium augmentation is such an important strategy in treatment-resistant depression and chronic suicidal ideation. For augmentation in unipolar depression, lithium doses are often lower than what we use in acute mania. But lithium is not a benign medication. You need to monitor kidney function, thyroid function, lithium levels, and hydration status. And you also need to educate patients about dehydration, NSAID interactions, ACE inhibitors, diuretics. And you need to educate them about toxicity symptoms like tremor, vomiting, confusion, ataxia. Lithium toxicity can be a medical emergency very quickly. It has a narrow therapeutic index and requires close monitoring. Now, let's talk about some of the newer serotonergic antidepressants. One of these is Vilazodone. So Vilazodone combines SSRI activity plus partial 5-HT1A agonism. People often remember this as kind of a SSRI plus buspirone-like activity. It may have somewhat lower sexual side effects compared to SSRIs in some patients, although GI side effects can still occur. Remember that this should be taken with food because absorption changes significantly without the food. The other one we're going to talk about is Vortioxetine. So Vortioxetine is sometimes favored when cognitive symptoms are predominant because it can help with poor concentration, slow thinking, executive dysfunction. It has multi-module serotonergic activity, and it is often perceived as relatively well tolerated. Some clinicians feel it may have lower rates of sexual dysfunction compared to traditional SSRIs, although this, of course, varies by patient. So we have talked a lot about different options beyond the traditional antidepressants. But what do you do if a patient partially responds to an antidepressant? If a patient has a partial response but tolerates the medication well, you can often augment instead of switching immediately. Common augmentation strategies include adding Wellbutrin, especially if the person is having sexual side effects from the SSRI. You can add on Mirtazapine, especially if they're still having issues with sleep and appetite. Lithium, think about suicidal ideations. Bupropion, thyroid hormone. You can even use second-generation antipsychotics such as Abilify, Caplyta, and quetiapine. But remember that every augmentation comes with a cost. More medications mean more side effects, more metabolic risk and EPS risk with those antipsychotics, and more drug interactions to be on the lookout for. And taking more medications can cause more adherence problems for the patient. You will fail your patients if you only think about the next medication when they don't respond to an antidepressant. As a psychiatrist, you need to think about, is the diagnosis inaccurate? Is underlying personality pathology contributing? Is trauma contributing? Is there substance abuse making the depression worse? Are sleep disorders causing them to feel more down? What about chronic pain or medical contributors that can cause depression? What about adherence? Are they even taking the medications like they're supposed to? Stressors that medication doesn't address? And do they have psychotherapy access? Sometimes medication failed because it was the wrong medication, but sometimes it fails because it was the wrong diagnosis or because depression was never the only problem in the first place. If you missed part 1 on choosing antidepressants, click on the video on the right. Subscribe for new videos every week.